main thing which I feel doesn't get enough importance is balancing the total hip. When we talk about balance, we're always giving a lot of importance to the knee, but we haven't really given that much of thought to the hip. But that's where I feel that it's very, very important, because an unbalanced hip will actually dislocate. So it's very important. I think everything about the hip is all about the balance. So there's a lot of tinkering required to get a good hip replacement done. If you break it down, it depends on all these different variables: the anteversion, inclination, height, depth, and then the femur offset, etc. And of course, the abductor sufficiency. But if you just zoom in on you can just do a quick thing of this. But if you actually zoom in onto these, and you will actually be able to whittle it down to three main things: component position, restoration of biomechanics, and soft tissue balancing. I'll just go into a little bit of depth on all these three. So acetabular component position is very, very important. You need to maintain that lever arm. So the longer the arm, the less amount of force is on the joint. So adequate medialization of the acetabular cup to the quadrilateral plate really helps to reduce the joint reactive forces. You have to try to maintain native hip center as much as possible. And of course, the positioning is usually better to be done in a Lewinick safe zone. So if you see a normal center of hip, may not be actually that medialized, but the cup, when you're doing, you have to medialize it till the quadrilateral plate to improve your joint reaction forces, to increase your femoral offset. The Lewinick safe zones, there's a lot of discourse about this in the recent past. They're saying that this is probably not the right area to put in, or you don't need to put in every case, but you need some starting point. So you can't just go in blindly saying that we'll see where it goes. You need to have some starting point. So acetabular anteversion of 15 degrees, inclination of 40 degrees plus or minus 10 is ideal. But now a lot of discourse on the combined anteversion, which I feel is more important. So combined together, the femoral and acetabular anteversion should be between 25 to 50. That's a different range for women and men. And of course, functional placement of cup, as Kiran sir was mentioning. Robotics do help in this, and especially virtual range of motion is something very, very interesting. As you know, component malposition may lead to a lot of problems, dislocations. Excessive anteversion will cause anterior, excessive retroversion posterior dislocation, and horizontal cups can lead to impingement as well. So you don't want to have any wrong positioning of your cup. So what about the femur? Femur component position is very important. Offset is something that we keep hearing about. The most important thing is this lateral offset. It's the distance between the center of the femoral head and the axis of the shaft. So the higher the offset, the less force on the joint. And of course, you have something called as the anterior offset. It's the same thing on the lateral view, and this adds to your combined anteversion. So as I mentioned earlier, if you have a hip which has a native high femoral offset, you want to try to increase your offset in the THR as well. So if you see a stem which has a lesser offset, is going to have lax soft tissues. Higher offset, you can actually end up nicely tautening your soft tissues. Component malposition of the femur can be in other angles as well. Varus valgus can be retroverted or anteverted, can be anterior or posterior placed in the lateral view. You should make sure that all these are properly placed. So stability of the THR depends on two main things: the femoral head and avoiding impingement. So let's talk about femoral head size. We keep talking about how the smaller head can lead to higher chance of dislocation, and a bigger head being less chance. The reason for this is when you have a bigger head, you have a bigger head-neck ratio. Okay, and that leads to a better jump distance. That's the distance that the neck has to travel before it dislocates out. So if you see over here, smaller head has a smaller jump distance and a bigger head has a bigger jump distance. So it's better to go for a 32 or above. That's up to 36. Impingement is a big no-no. We have bony, implant and cement impingement. Any impingement will lead to dislocation. So this is an implant impingement. This is a bony impingement. You want to avoid both of them. How do you avoid it? You have a proper implant positioning. Obviously, if you have too anteverted a cup or too horizontal a cup, sometimes you will impinge. You have to restore the offset, so you may have to use higher offsets or even higher neck lengths. Bigger head size, as I mentioned earlier, will help you. Dual mobilities do help in cases where you're not able to avoid the impingement. Removal of the osteophytes is something that we really have to concentrate on. If they're very big and after implanting your cup, you have to take out the osteophytes. Avoid big lip liners, and robotics, again, virtual range of motion does help to avoid. Just show you how this helps. See this particular case. This is a striker Mako. This is before implantation, before training. You can just try to see whether you're having any impingement. In 30 degrees of external rotation, he was impinging on the back of the cup. So what we do is we just go and reduce the anteversion on the cup to around 23, and that gets rid of the impingement. This is one way to look at it. Leg length is very important, especially in the present scenario. People are coming and asking only about leg length nowadays. So more than 3 to 4 centimeters short, you have to go for STSO. Again, you have to differentiate between supratrochanteric and infratrochanteric. I won't dwell on this because Dr. Suhas will speak about this later. So I'm not going to speak about these two. Now let's move on to the soft tissues. This is where a lot of us don't really pay that much of attention, but I think it is one of utmost importance to restore the native tautness of the soft tissues. So one is the capsular ligaments. In the front you have the iliofemoral and the pubofemoral, and of course the labrum. And in the back you have the ischiofemoral. If you get your offsets and everything correct, all these will be correct. And then of course your hip girdle muscles, your flexors, extensors, adductors, abductors, and external rotators. In these, I think the most important will be abductors and the external rotators, because in posterior approach we are going through those. Soft tissue tension, as I mentioned earlier, can be improved both with neck length and with increasing the offset. But the differences between these two here is, if you increase the neck length, you get a tautness of the muscle, but you also get longer leg length. But if you increase the offset, you'll get the tautness of the muscle without increasing the leg length. So that's something to remember. If you need tautness as well as length, increase the length. If you need to get tautness without increasing the length, just increase the offset. So again, this is what it looks like. This is a longer neck, and this is what you have by a different offset. So in Accolade 2, you have 132 and 127. So you have, various implants also have that option. Now, how do you evaluate your soft tissue, whether it's balanced or not? So trial reduction is important. If you're finding it too difficult to reduce, that means you're too tight. If it's going in too easily, that means you're too loose. And then you can, of course, use the shuck test, which nowadays is going out of going into disrepute, but people still do it. Flexion contractures, you can check with the drop kick test. Extend the hip, and if your knee is suddenly extending, that means you're too tight. You may have to change your offsets. Anterior instability, so if you extend and external rotate, if you're popping out in the front, that means your cup is probably too anteverted, or you have too many posterior osteophytes. You have to work on both of these. Try to maintain at least 1 centimeter space between the ischium and the posterior aspect of the GT. Leg length restoration, as I mentioned earlier, in the pursuit of adequate tissue tension, sometimes we end up lengthening the limb. If you have too much of limb length discrepancy, you need to assess what is the cause. You may have to take a deeper neck osteotomy and sink in your stem further down if required. Adductor assessment, sometimes you have very tight adductors, you're not able to abduct the hip. If it ends with a hard endpoint, that's probably because your implant is impinging against the lateral pelvis. Okay, there you'll have to see if you can increase your offset, that may help. But tightness with a soft endpoint is because of tight adductors. There you can finish your case, make the patient supine. Under sterile condition, you can do a nick on the adductor longus, and that will help to release your adductor tightness. Posterior, most of us are posterior surgeons, I am myself. So first check in a sleeping position, 90 degrees of flexion with slight adduction. There should be no posterior dislocation. Then you check in full flexion and in 90 degrees, and internal rotate, you should not have any posterior dislocation. Causes of posterior dislocation, you may have more vertical or a retroverted cup. Inadequate abductor tension is one of the most important causes. Inadequate combined anteversion, inadequate femoral offset may cause it. Anterior osteophytes can also cause it. So proper soft tissue closure is very important. That is the Ranawat suturing, which most of us do anyway. So before we end, just a quick classification of the different types of instability. If you don't balance your hip well, you can end up in instability and dislocation. So this is a table. If I'll go into each one. Type 1 is because of acetabular component malposition, where you are outside the Leuvenhoek safe zone. The solution, acetabular shell revision. Type 2 is because of femoral component malposition, outside femoral anteversion of 20 degrees plus or minus 10. You have to revise the femoral stem here, obviously. Type 3 is because of abductor complex insufficiency or detachment of the gluteus medius. In either of these cases, you may have to go to a constraint liner or a dual mobility cup. Type 4 is because of impingement. As I said earlier, it can be bony, component or cement impingement. So you have to remove the cause of the impingement and probably go for a larger head. Increasing the horizontal offset also can help you here. Type 5 is because of delayed polywear. This patient will be good for 10-15 years and suddenly they'll dislocate, and you'll find in the X-ray an eccentrically placed head. That's because of polywear, and you may have to go in and take out the cup and change the cup. Type 6, unknown cause. You have to revise everything, but always be ready for all 6 possibilities. Okay. So how do you address all these things at once? The robot does help. I'm not going to depth of robotics, but I just want to show you have a better 3D planning. You can actually assess all the limb length discrepancy, the center of the hip, the acetabular component placement, all the things we spoke about earlier for proper balancing can be done with the robot in the planning itself. And then as I showed you about the virtual range of motion, same thing, you can check it beforehand. And just an example, this is a case where you can put in a stem version. You had a big posterior impingement. All I had to do is reduce the anteversion. Never go down to 12 anteversion usually, but this case I actually went down and had a very nice and stable hip. So very important to balance the hip, make sure that you spend more time making sure all these components, that is implant placement, offset and biomechanical restoration, and then of course the soft tissue balancing. Thank you.